Ma'am, please start.
Thank you, Pallavi ma'am. On behalf of Maharashtra IIP, it's my privilege to welcome you all for today's academic session, Thalassemia Beyond Basic and Beyonds. This program is part of our continuous commitment to enhancing the awareness, improving the patient care, and uniting the pediatric community under the theme, Together for Thalassemia. Uniting communities, prioritizing patients, hashtag we are one, hashtag patients first. The thalassemia, as we know, it is not just a medical condition, it is a lifelong journey that affects the patients and families deeply, physically, emotionally, and economically. With the India being one of the country with the highest career rate, the need of education, prevention, and accessible treatment is more urgent than ever. This session has been thoughtfully designed to cover the key aspects of the thalassemia care, right from understanding the disease to its supportive management and curative options like the bone marrow transplant. We are honored to have with us a panel of experts and leaders in the world of pediatric hematology who will share their insights and practical knowledge with us. As we come together this evening to share our responsibilities to educate, to care, and to work towards a future of these children. Now, I would like to invite our President, Maharashtra IIP 2025, Dr. Sanjay Pakmode sir, to deliver a welcome address.
Thank you, Kashmiri. Namaskar. Good evening. As everybody is aware, 8th May is celebrated as World Thalassemia Day. Now, as Kashmiri has already told, given the brief information about the thalassemia, and every year there is a theme for thalassemia. So this year the theme is Together for Thalassemia, Uniting Communities, Prioritizing the Patients. Now this theme emphasizes the importance of patient-centric approach, advocating for holistic care that addresses not only the medical but also the social needs of the individual, social, emotional needs of the individual living with thalassemia. It also encourages the international communities to prioritize the thalassemia patients in the healthcare policies. And today we got the galaxy of panelists who will be telling about the overall overview. That's why the topic is named as Basics and Beyond. And then the treatment, and then the what are the new modalities of treatment available, how to get rid of the disease. Now, the first duty is thalassemia. We should not allow the children to born with the thalassemia, but if that is a duty of every pediatrician or rather every physician over here. And if at all they are born, how to deal with those particular patients and the people living around those people. First of all, I means yesterday only we got the Operation Sindoor, and our soldiers are fighting at the border. And let us pray for the well-being of all the soldiers, and let us also pray for the sovereignty of our country. So with this, I hand over the mic to the Kashmiri.
Thank you, sir. Now I request Pallavi ma'am to share slides. Pallavi ma'am? Yeah. So our beloved Secretary of Maharashtra IIP is not with us today. He couldn't join today. So on behalf of him, I welcome you all for today's session. And before proceeding further, I welcome today's speaker, Dr. Tushar Idhate. He is
Kashmiri, 1 minute.
Yes.
Actually, yes. Vinky sir contacted me means because of some other meeting, because he's already
No, no,
dealing
sir.
with the Thalassemia Society.
I'm just
Ah,
introducing first,
ah.
and then the sir's lecture will be first. Yes. Yeah. So, Dr. Tushar Idhate, sir, he's from Chhatrapati Sambhaji Nagar. He has done his fellowship from Apollo Hospital, New Delhi, special training on pediatric oncology from Tata Cancer Hospital, Mumbai. Also, he has done the various fellowships from UK and Singapore. And he's the associate life member of pediatric hematology and oncology chapter of Indian Academy of Pediatrics. Next, ma'am. Pallavi, ma'am. Then we have a very eminent speaker with us, Dr. Atish Pakane. He has done his UG from Nagpur and PG from KM Mumbai and DNB from Chennai. He has done the hematology fellowship from Sir Gangaram Hospital. Also, he has done the FIAP, pediatric hematology, oncology, and bone marrow transplantation. He's certified European blood and bone marrow transplantation and international transplantation course in Barcelona, Spain. He is also the first person to do a successful BMT in hemoglobinopathy in Vidarbha region, and also associated with the NGOs working for the tribal populations. Welcome you, sir. Next, ma'am. And we have the most eminent speaker and our guest of honor for today, Dr. Venki Raghuvani, sir. He is a senior most pediatrician. He is administrator, Maharashtra Medical Council, Mumbai. He is a member of Medical Advisory Council, National Medical Commission, Delhi. Also a director, Thalassemia and Sickle Cell Society of India. Ministry of Tribal Affairs and Government of India, National Sickle Cell Elimination Mission. He is also a member of that. Then also a director of the Thalassemia and Sickle Cell Center, Nagpur, president of the Global Sindh Directors Association, Maharashtra State Blood Transfusion Council, Mumbai. He's a governing board member of that. Then the chairperson of Sindhi Hinda Vidya Samiti, and also executive board member of Indian Medical Association, Nagpur, executive body member of Association of Medical Faculties, Nagpur. So with this note, I welcome you, sir. Sir is a guest of honor for today's program. So I first request sir to give a address the gathering and then start with his topic. Over to you, sir.
Good evening, all.
Good evening, sir.
Good evening, sir.
The president, my friend, Dr. Sanjay Pakmode, secretary, Dr. Amol Pawar, all the office bearers, and today's all the delegates who are attending today's very important uh, socially connected topic. So I'm not going to, as far as thalassemia is concerned, we are going to we'll hear much from Dr. Tushar and Dr. Atish Bakane. I'm going to talk more of, socially, what thalassemia uh, means for these patients of thalassemia. So we all know that it is a dreaded problem. It is a problem which makes the family cry, we can say. Is a child having 6 months of age, whenever not, having a hemoglobin of normal value, goes to a physician or a pediatrician, and the pediatrician does the test and ultimately diagnosed with a dreaded problem of thalassemia major. And after that, he requires transfusion every monthly in the initial days. And as the age increases, the requirement of transfusion also increases. First for every 25 days, next after few years, every 20 days, and at the adulthood, at almost every 15 days. And also, depending on the weight of the child, 2 units are required every 15 days. So we can say that in adult age of for the patient of thalassemia, 4 units of blood is required every monthly. So this we can understand the agony of the family and the child, where this particular blood transfusion, the repeated blood transfusion is required. Not only that, they require lot many medicines like iron chelators. They also require, they have to undergo lot many tests, investigations also. So what I feel like we should also look in the perspective of the family of the patient of thalassemia. Now, uh, I can say that somehow these patients of thalassemia are neglected, not by the government only, but I can say by the community also. And somehow we doctors are also responsible for it. I will explain it in details. Now, a patient of thalassemia, we all know that required blood transfusion, and we have to keep his hemoglobin pre-transfusion level not below 9. It should be above 9 at before the transfusion, pre-transfusion level. For that, he needs to be given blood transfusion very frequently. And how many centers are available for them to give blood transfusion? This is a question. We all know that these patients of thalassemia, they do visit to the government hospitals where they are sent back because of not availability of blood many times, because of not availability of, they don't have beds sometimes for these, because this is, they say this is not an emergency, you come tomorrow and day after tomorrow, and the patients goes back and he comes after 7 days. We can understand the hemoglobin of 8 grams, 7 grams becomes 5 grams, 6 grams after 8 days, 9 days. So this is a practical difficulties these patients face. It is all because we all know that we pediatricians, I'm talking about pediatricians, we are all pediatricians, that we usually, the trend in our pediatric practice is that these chronic patients of thalassemia are usually sent either to the government hospital or the trust hospitals or the centers which are dedicated for the transfusions. Why not we ourselves start giving transfusions to thalassemia patients? I tell you, it is not difficult. It can be done, and it will definitely going to help these patients. So this one aspect, this is a one aspect. The another thing is these patients are getting free blood because there is a government GR that in the state of Maharashtra, thalassemia patients will get a free blood from the blood banks. So the blood banks have a duty to provide a free blood, but there is always a problem. They don't get sometimes in the summers, and especially in the summers these days we do face a lot of difficulties in getting blood for these patients. So we have to uh, have a number of people who should voluntarily come and give blood donations to for these patients. Now I tell you that whenever these patients get blood from the multiple donors, there are all chances of getting the antibodies developing in their blood and having the subsequent reactions. So it is always better to have a pool of number of donors for these patients, which we do. What we do is we fix up the 15 or 20 donors for each patient so that they will have a less type of side effects because of the less development of the antibodies in them. So this is one strategy which we need to follow as far as the blood transfusion in thalassemia major patients is concerned. Now, another thing is while giving blood to these patients, I am talking all about this, in a social way, what we can do. So, whenever we give transfusions to these patients, very oftenly these patients get the whole blood, which is not a protocol. Actually, they should be given only PRC because whole blood contains plasma, whole blood contains WBCs, platelets. So WBCs are the one which are responsible for so many infections which are carried in these patients. So we all know that because of the breakage of WBCs, there are lot many cytokines are also released, which create the reactions in these patients. So we have to remove the WBCs. For that, we should have a leukodepleted blood. Now, for leukodepletion, the best one is which is done pre-transfusion level at the blood bank. But If it is not being done, then the leukocyte filter should be used. Again, a problem is here that the leukocyte filters are very costly affair. It is costing minimum of 1,000 rupees and even more. So we should have, I will come out later on that what are the issues and what can be done at the government level also. So these patients cannot afford to have leukocyte filters because of their cost with each and every transfusion. But ideally, they should be given this blood with this leukocyte filters. Another thing is that these patients, they get infections. There are chances of infections like hepatitis B, hepatitis C, HIV, and all because of the repeated transfusions. We all know that NAT testing always will reduce the chances of these infections in these patients. But unfortunately, again, these patients, all patients cannot afford NAT tested blood every time. So this is another thing which is being, told to the government to provide NAT tested blood to these patients because blood bank gives them blood free of cost, but they don't give them NAT tested blood free of cost. So they need to spend for it, which they cannot, and hence this is another issue as far as the transfusion in thalassemia major patients is concerned. Now, once this we talk about this transfusion part, we all know that because of the repeated transfusion in these patients, there is a deposition of iron in the different parts of the body. The iron is deposited in the heart, in the liver, in the kidney, in every organ of the body, and hence there is a dysfunctioning of these organs because of the damage to the organs by this deposition of the iron. Hence, we need to give iron chelators, which is one of the most important therapy in these patients to prolong their life for making the good quality of life in these patients. And these iron chelators, which are nowadays available, previously they were not, now they are. So we can use them in optimally, in a good way, in a best way, and we can increase the quality of life of these patients. We have three type of iron chelators. We have injectable desferol, which is only used in emergencies. Whenever the ferritin or the iron chelation, the very fast iron chelation is required. We have deferiprone, which is called as Kelfer, and it is also a drug which is nowadays being used, but in a lesser way, lesser quantity, lesser in less number of patients. The most common drug which is used for this particular iron chelation nowadays is defrosirox. We all know there are like Desirox, Asundra. These are the different companies which are making these drugs, which is to be used in 20 to 40 milligram per kg. Now, the social issue about these iron chelators is that it is not available at the rural hospitals. It is only available in the district hospitals, but not in all district hospitals. We have in Nagpur, the availability of district this iron chelators. Our friend Dr. Sanjay Deshmukh is looking after those patients in one of the district hospitals over here. But it is not the case in all the hospitals in our state. So we need to ensure that the government should provide these iron chelators at the rural level. A patient cannot come to a district hospital by running for 100 or 70, 80 kilometers and for 15 days iron chelators. So this iron chelator is of utmost importance because we all know that if we don't use these iron chelators in these patients, ultimately they will die of cardiac failures or even hepatic failures or even renal failures. So these iron chelators are of utmost importance in these patients. Another thing is about the investigations. Now, we all know that these patients required to be done CBC every pre-transfusion levels, and also they should undergo serum ferritin because it is one of the indicators which tell us that how much is the iron has been deposited, how much is the iron overload. Although it is not a it is a crude method, but that is a practical method which is available at the which should be done and which is normally done for these patients. But nowadays we all know that if we want to know the exact status of iron overload in these patients, we should do T2 star MRI. Unfortunately, again, it is not available at all places. It is only available at the big cities and the metros. The availability of this T2 star MRI. See, it is a very simple thing. Any MRI center can have a software and they can train a person and they can start. Even the government hospital can do that. And this is the the if the government wants that they should if the government feels like it can be done, so it is another thing which we all know that it should be made available so that we can know the exact status of iron overload in these thalassemia major patients, which is very important as for the management point of view, for knowing the how many iron chelators we should use, how we should use, and for this is all is required. Now, as far as these patients are concerned, we all know that this is about as far as the management we have. In addition to this ferritin and CBC, they need to undergo, they need to do this KFT, LFT, serology, because we have to see the status of the kidney, status of the liver, and also echocardiography to see the status of heart, and of course they have to do a serology because I just told you that infections are very common in these patients, so they should do repeated serology also. Now these patients, as this is how the overall management of these patients, and how important to have these facilities in our place. This is what I wanted to tell you. Another one thing is that there are the few advantages these patients have got in the recent past. One of them is they have got a disability certificate. That means they will be getting 4% reservation in education, but they have not yet received reservation in an employment. So they need to be given employment reservation in employment. This is one other demand that we are put in front of the government, because ultimately they have to struggle a lot even in their studies, because they don't get time. The most of their time goes in transfusions and everything. So we have also asked the government, we have requested the government to give them reservation even in the this employment. So this is what this is a nutshell I have told you. Now, the most important part is prevention part. Now we all know that this thalassemia major child is born only when the mother father are thalassemia minor. The thalassemia minor is absolutely normal person. There is no issue at all to him. But when a boy of thalassemia minor marries with a girl of thalassemia minor, the child will be, there are 25% chances of getting thalassemia major. So we must give importance to this thalassemia minor test before marriage. So the A2 quantitation in a HPLC is utmost importance, which should be done in all people, even every boy and girl should undergo this particular test. Unfortunately, we even in our medical fraternity, the onus goes, I think it is on the obstetricians. We have so many times told, we have requested the FOSG, we have requested the obstetrics and gynecologic associations to make their members sensitize about doing this particular A2 quantitation in their pregnant ladies. But I think it has not been done. It has not been started. Only few patients are undergoing this test, which is very unfortunate situation. Now, we have even reached to the government and we have asked them to make some law so that every person gets this particular test. I tell you, in our organization have done, we have started this particular test of pregnant ladies in the first 3 months of their pregnancy in 28 medical colleges of Maharashtra. Our organization have done it. We have done till now 37,000 tests in last 2.5 years to all these patients. We have found so many positive pregnant ladies. We did we in those ladies in which we got this test positive, we have checked their spouses, and in those where both the husband and wife were positive, we have done CVS testing at 12 weeks of pregnancy, and even we got few positive fetuses in the CVS testing, and we counseled them for getting them aborted. So this project we are running, and I tell you that this project we are doing at a total free of cost. We have not taken even single rupees from the government for this project. We are still continuing this project. I appeal the pediatricians over here that they should, make this people aware. Even they should tell their gynecologists and obstetricians colleagues that this test is of so much importance. By I think the investment on the prevention is much lesser than the investment on the management of so many people who are doing. We have 1.5 lakh patients of thalassemia major in our country, and still we are not able to control the new births of the thalassemia major. So it's onus on, and it is all depends on us how we go. And we fraternity, our medical fraternity, we doctors, we pediatricians play a big role. Now our the thalassemia, this our IAP national president Dr. Khadatkar has really he seriously taken this issue. I had a talk with him also. My friend Dr. Sanjay Pakmode was also there. We have discussed that we will do good for this, that we should make people aware of this particular aspect, which is of utmost importance, and we will be able to control the birth of thalassemia major child. Our society runs one center at Nagpur where we are giving free transfusions, free medicines, free investigations to 500 patients of thalassemia major. Almost every day, 15 children are coming to our center for the blood transfusions. We are also doing the free HPLC testing for the for the prevention. So we are trying to do on our level, but I think the it is the effort which needs to be a collective one. It has to be done not only on one medical fraternity, but it is to be from the start from the government, and it should reach to the last individual. So I think this is what I wanted to put in front of you. Thank you so much, the organizers, especially Dr. Sanjay Pakmore and all, for inviting me on this occasion. Thank you so much. Namaskar.
Thank you, Vinky sir, for your the social angle you have shown and lot many things you have introduced. I mean, you told us so that you sensitize all of us ki what is our duty towards thalassemia. So I think with your talk, we assure you ki we'll be dealing with this problem on the agenda, and we'll be sensitizing our obstetricians people also about the HPLC in the so that in the ANC period, so that accordingly will not allow the thalassemia patients to be born. Kashmiri, in the introduction, I may add one thing. Dr. Vinky sir is the aspirant for Padma Shri for his extensive work in thalassemia.
It is not. It is to be given. Padma Shri is given to the very, big people, those who have done years of work. We are very small people.
Now we are
So,
seeing since I started my practice, I know what work he's doing in Nagpur.
thank you, Sanjay. Thank you.
Thank you, sir. It
Thanks a
was
lot.
really grateful to have you here because you have set the stage with the clarity, compassion, and impactful overview. We are all speechless, and we have got so much of information about the thalassemia regarding the facilities which the children are having, and you have you have given the clear guidelines what is to be like, what is there for the children. Thank you, sir. Any questions from the audience? Because sir has to go, so I'll take the question for sir first.
So I will just like to comment, sir. It is I can just see the passion with which you spoke, and even though we are practicing pediatric hematologist, but you can just sense it in the talk you have given, and I really have tremendous respect and sort of. From the community, I would like to thank you for this, service, because I was a student of Dr. Mamta Manglani ma'am, and I know, how difficult it is to develop a center at any place, even though it was a tertiary care center like a Sion Hospital, and where you are doing it in Nagpur, and when you must have started, the challenges and the problems you must have faced. So I'm really glad, sir. Like you, I had heard the name, but to listen to you with the passion. I'm thankful to you for sparing your valuable time, and I can see many of youngsters have joined today for this talk, and you are the best person I feel to have you to speak on the thalassemia. Really, thank you.
Thank you. Thank you, Tushar. Thank you so
Thank you,
much.
Venki sir. Thank you. Thank you.
Any questions from audience? Okay. Let us move, sir, for the next talk. Sanjay, sir. Okay. So let us proceed. Our next speaker is Dr. Tushar Idhate, a pediatric hemato-oncologist from Chhatrapati Sambhajinagar, who will discuss the supportive treatment of thalassemia, a core aspect of ongoing patient management. Over to you, Dr. Idhate, sir.
Yes, ma'am. So, can I share my slides now?
Yes, yes. Yeah, you can share.
Just
Pallavi ma'am, make them a co-host.
Already done, ma'am. Already done.
Okay.
can you see the
Okay.
slides, ma'am, now?
No, not yet, sir.
Not yet.
Not yet, sir.
Just a minute.
Kashmiri,
Yes, sir.
yeah, you have made the people's muted. That's why we're not able to ask the questions.
No, I have
So
not made, sir. I have not made.
just
No,
now
sir.
unmuted the
Ye-
people's. So
Yes,
uh,
madam. We also wanted to ask and share the comments, but we were not
yeah,
being
so
allowed by the
always
host.
Okay,
make
okay, sir
sure
is
to
here, I
keep,
guess. Sir is here. I'll just check it out. Sir is here.
I want to I
Raghuvani,
am
sir,
Dr. Sanjay
people
Deshmukh.
wants to ask you
Yeah,
question
Rugwani
because
sir,
of
are you
sir.
there?
Yes,
Or
yes.
Yeah.
Because
if we
of
can
some
get
technical
if we can
error.
get if we can get an email address, can we send him questions?
Hey, I
For
am
Yeah.
example,
And we want to add further, Dr. Pakman sir rightly said, we know how much Dr. Rugwani sir is after the stakeholders in Maharashtra and at national level to get the benefits of treatment modalities, the screening test through his all contacts to make it happen. And in Nagpur, what he is doing, we are witnessing the his commitment in the thalassemia disease awareness and management. And in Daga Hospital, sir is conducting free of cost space screening to all antenatal patients. So we should be pursue this matter on by MahaAP along with Dr. Rugwani sir. So I request Dr. Pakmode sir to have the pursuance along with him so that the government of Maharashtra go for the neonatal screening.
Definitely, definitely. We'll
Thank you.
Sir,
Thank
may
you.
I?
Yes, ma'am.
Sir, good evening, sir. I am at Navi Mumbai Municipal Corporation, and I have been looking after thalassemia daycare patients. We have around 78 patients. I am also postgraduate student of Dr. Mamta Manglani from Sion Hospital. Now we are starting with NBS. My question is how sensitive it is by capillary method to diagnose hemoglobinopathies, especially thal and sickle, as NBS screening.
So, yes, it is quite sensitive. Nowadays, Nowadays, it has been recommended method, and we are not only you, but many people are using it. Even nowadays, most of the hematologists are also suggesting of using it. So you can you proceed with it. There is no problem at all.
Okay, sir. Thank you, sir. Sir, another query. We are trying to get all these drugs from like Kelfor, we are trying to get leukocyte depleted filters we have taken on tender. But is there any provision through NUHM or some other place from where we can have some state getting associated with this, or how exactly do we go about it?
It is very clear. The what government says is, if some facility is present in a government setup near to you, they will provide that particular facility in that setup only, cannot give to a private or a trust one. So if you are running a trust or center or a private center, then you are not going to get it. Are you running
Sir,
a
ours is a municipal, sir, no, sir. Ours is a municipal corporation.
so
Actually, I have been in contact with
you
you from PGIMS, like standalone medical
so
college also. So,
then
is
you
there any provision?
Yes, then what you will need to do is that Dr. Sanjay Deshmukh, is running one center at the Daga Hospital at
Yes, sir.
Nagpur. So likewise, you will have to
Yeah.
project how many patients you have. 67 number of patients. So these number of patient is an
Yeah.
ample. You can one make a project
Wait
in
a minute.
to Dr. Kendre is there. Dr. Kendre, you can have. I can I can help you out in that. You just make a project and contact me. We will definitely pursue.
Hello.
Okay.
Thank you.
Okay, sir. Thank you so much, sir.
Rugwani sir, I have one question. Rugwani sir.
Yes, Sanjay.
Yeah. Uh, so as per the recommendation, we should the blood transfusion has to be NAT tested, and you should have a lot of options nowadays for the blood transfusion. But still, so many patients are receiving the whole blood transfusion. So, as a stakeholders in thalassemia, what are the policy you are making so that the kids should not be receive whole blood? Instead of whole blood, they should be receive, the recommended.
So the straightforward answer is that our country, we all know that there are some issues of the resources. We all know that in the villages, we don't have blood banks, even blood banks. So where the blood banks are there, they don't have a PRC facility. So giving a whole blood is better than giving no blood. So where there is a not availability of PRC, there is no other option. You need to give a whole blood, but it should be avoided as far as possible. If you see the picture 10 years ago, the things were totally different. Almost 75 to 80% were getting the whole blood, but now I know that the figures that we have estimated is only 10 to 15% are getting the whole blood. Rest of them in our state are getting the PRC. So the things will improve. We all hope that in recent future, in very soon, we will achieve this target of 100% of PRC blood.
Sir, can I ask a quick question?
Yes, why not?
So, with so much going and with genetic predispositions, what is the proactive prevention that the government is planning, or through?
So, let me tell you that the government has started the sickle cell mission 2 years back only, and they are having they have to they have a they have already tested 4 crore people as far as the sickle cell is concerned. But unfortunately, the thalassemia mission has not been started. The reason being, the thalassemia test for the prevention is HPLC test, confirmatory test I am talking about, is a
Yeah.
HPLC test, which is a costly one. So the government is thinking like once they start this thalassemia mission, they should have a facility of testing crores of people with this HPLC test. So definitely we are expecting something will come out, and the government will roll out this thalassemia mission, and everybody especially the youth. As we all know that in sickle cell, what they have done is they are now testing to every person who is up to 40 years of age, especially in those who are residing in the tribal districts. So similarly, we all expect that the government will come out with this thalassemia mission in future.
Thank you, sir.
Sir Rugwani sir, can I ask you one question?
Yes, madam.
Hello. Sir, can ANC mothers under JSSK, in our hospital we have Janani Suraksha being a corporation municipality hospital. So
Yes.
under JSSK, can we have, I'm trying my level best to put somehow HPLC of and my hypomicro mothers, but I don't know how. I mean, I'm not able to get it done from the portal or how to incorporate it as a free method for the at least high
So,
risk mothers. Those are who
yes,
are having
yes.
hypo.
So answer is HLL lab. Hind lab, HLL lab has been given a responsibility in the state of Maharashtra by the government to do all the tests free of cost for the government hospital patients, which is not being done at that particular hospital. So I don't know whether your hospital is having this HLL lab attached with you or not. It is there? Is it there?
It is, yeah, it is attached, but it is attached only for those 3-4 tests like
No,
CBC and
that is what you need to do. You have to ask them to increase the number of tests and include HPLC test in that. So they will do it, and they are
okay.
doing it in other places.
Okay, sir. Thank you
For
so
the
much.
further questions, I'll request Vinky sir. Can I share your mail ID afterwards?
Yes, you can even
With
my
the delegate.
mobile number you can share.
Yes, yes. Thank you, sir. Thank you.
Thank you, sir.
Yeah.
Thank you.
Yeah, thank you. I've got
so
3
much.
more questions.
Thank you.
Thank you.
Thank you.
So much.
Now I request Dr. Idhate sir to proceed further.
Can you see the screen, ma'am?
Yeah.
Okay. So, because the most of the part is actually covered by sir, so what I will do is there is a lot of overlap between my talk and what sir has already covered. So I will try to cover those things, sort of which have not been covered because it's already 9:50 also, and we have to hear the BMT talk also. So I will stick to those points which I feel are sort of not covered or need to emphasize only that I will try to cut short. So this overview of the talk uh, is the overall epidemiology. We all know now, sir has mentioned, we are the sort of one of the major countries where the thalassemia is there. Hemoglobin structure we know alpha 2, beta 2. Adult hemoglobin we know fetal hemoglobin and A2. So what is
Sorry
thalassemia?
to interrupt. Can you do a full screen?
Yes, ma'am.
Yeah. Thank you.
Yeah. So it is a single gene disorder with autosomal recessive inheritance, and there is a defect or reduction in the production of globin chains, either alpha or beta. We know there are 3 types of thalassemia: minor, then there was something which was labeled as intermedia. This is the one point which is not covered, so I would like to emphasize on this. So this is called as NTDT, that is non-transfusion dependent thalassemia. And then we have thalassemia major, which is now labeled as a TTD, that is transfusion dependent thalassemia. So previous intermedia has been now labeled as NTDT, and thalassemia major is now TTD, that is transfusion dependent thalassemia. So this is a newer classification. So as you can, if you start from the left side and you move to the right side, there is a spectrum. There is a beta thalassemia minor, alpha thalassemia minor. Then there are in between 3 to 4 disorders. If I will request you to see below the red sort of arrow. So you can see beta thalassemia and alpha thalassemia minor. Then there is beta and HB, beta thalassemia, HBC, S beta thalassemia, E beta thalassemia. So these are, sort of compound heterozygotes, what we call. They will fall into the category of non-transfusion dependent thalassemia. Even though HBBB, that is homozygous beta thalassemia, can also fall. I will dissect this out later in the course, but I just want to highlight that this is the spectrum of thalassemia. It starts with minor, then there is a something called as NTDT, and then there is a TTD. So NTDT is something which requires occasional transfusions, intermittent transfusions are required, while the TTD is, as the name says, it is a transfusion dependent thalassemia. Okay. So pathophysiology of thalassemia, we all know there is a reduction in the beta globin synthesis. So there is a overproduction of alpha precipitates are formed. They get deposited in the cell, which leads to ineffective erythropoiesis in the bone marrow, and there is a resultant anemia. This ineffective erythropoiesis also causes extravascular hemolysis, and there is a extramedullary hematopoiesis. Okay, so ineffective erythropoiesis leads to anemia, and extramedullary hematopoiesis leads to all the hemolytic phases, hepatosplenomegaly, all the changes we see in thalassemia routinely. Clinical presentation, we know it starts from 6 months to 2 years. There is a pallor, hemolytic phases is there, organomegaly is there. Laboratory diagnosis, CBC, peripheral smear, and HPLC, what sir was mentioning. So electrophoresis was an older terminology. Now it is called as high performance liquid chromatography. We all know that in thalassemia major, HbF is the one which is increased and normal HbA is reduced and A2 is normal or elevated. Nowadays, we all are moving towards the genetic test. So we can do the genetic testing also to confirm the diagnosis. Now, this point is especially important when you get a patient who presented with anemia and has been already been transfused somewhere else, and then the patient comes to you. Now, you are clinically you are suspecting that this looks like thalassemia major, but you don't know how to diagnose. So there are two ways. Either you can do parents electrophoresis, where both will be thalassemia minor, and baby's electrophoresis can be done. But the baby's electrophoresis is done from a post-transfusion sample, so results are not reliable. But if you get a anemia, hepatosplenomegaly, age is matching, both parents are thalassemia minor, and electrophoresis is also showing some change fitting with the thalassemia, you can still label it thalassemia major if the patient is not financially affording for a genetic test. But if you have a post-transfusion patient and there is a confusion, you always can do genetic test, which will confirm the mutation. There are 5 common mutations in India. So they will test one of those mutations will come positive. When the homozygous mutations are noted, you can label it as a thalassemia major. So even if a patient is transfused, you can still diagnose thalassemia major with a 100% confirmation. Now, as I mentioned, sir has with so much passion mentioned that there are so many people involved in the management of thalassemia, and it is not just a one person's work. Uh, so everybody has to sort of take initiative and be the part of that. This all has been covered. I will not go into too much detail of that. So the primary goal is to cover anemia with transfusions, remove the iron, detect complications, bone marrow transplantation, and prevention. So just for the PGs who are there, whenever a new patient of thalassemia major is diagnosed, what should you counsel? So you have to tell them what is thalassemia, how it is inherited, why there is need for regular blood transfusion. You have to, in the first setting only, you have to give them a ray of hope and tell that there is a transplant option where the patient can be cured. So just don't say कि इसको जिंदगी भर blood देना पड़ेगा अभी ऐसे रहेगा. So you always now because the transplant facility is so much available, Atish is going to cover it. So the transplant has to be told in the first sort of diagnosis disclosure itself, that ray of hope has to be given to the family. Family screening is important, and definitely whenever there is thalassemia society is active in your city, you should register the patients. That gives them the moral support. Pre-transfusion hemoglobin, super, hyper, all that had been gone. Now it is the only physiological. Maintaining pre-transfusion hemoglobin between 9 to 10.5. Post, we generally don't monitor, that is not required. Sir has mentioned what is leukodepleted. I will also cover it quickly. So the optimal transfusion is something which will achieve appropriate growth. There should not be any bony or physical changes, and minimum transfusion iron overload should be there, and there should be suppression of extramedullary and intramedullary erythropoiesis. So this point sir has already covered, but I would like to emphasize that there is a 10 to 30% risk of alloimmunization in these patients because of repeated transfusions. It is especially more common in patients who begin transfusion after 2 to 3 years later on in their age group. So this one point I want you to emphasize in your blood bank, that before you start the patients on regular transfusion therapy, you should do extended red cell phenotyping. What I mean is AB and plus positive negative RH, AB and RH system we routinely do, but minor antigens such as C antigen, D antigen, E antigen, KEL, Duffy, all this antigen testing should also be done. As sir has mentioned, even in Chhatrapati Sambhajinagar also, we have got the donors. 8 to 10 donors are assigned for one patient. Those donors will come in rotation and they will only give the blood to that patient. Now, what we are doing is we are routinely doing extended typing of a patient also, and based on that typing, we are selecting a donor. So they are, highly matched donors for that particular patient. So the risk of alloimmunization is drastically reduced in these patients. So before you embark on the transfusion therapy, extended red cell typing of the patient should be done. And whenever the transfusion is given, you have to advise the blood bank to give maximum, matched uh, donor's blood to this patient to avoid the alloimmunization. This sir has already covered, so I will not go into too much detail. Leukodepletion, sir has mentioned, it is very important aspect, because normal WBCs which are present in a 500 ml of PRBC is more than 2 into 10 raised to 9. So this is a high count of WBC. We don't want WBCs to be given to these patients. We just want RBCs to be given. So what is the purpose of leukodepletion? It is depletion of WBCs. How it will help? It will decrease the contaminating white cell, resulting into decreased alloimmunization. It will also decrease your febrile non-hemolytic reactions. It will also decrease CMV transmission. So it is very important not only for the patients who are going to receive transplant, but for routinely also. As sir has mentioned, there are three ways. Ideal is pre-storage. In the blood bank itself, before you store the blood, leukodepletion should be done. Iron overload, this part also sir has beautifully covered, so I will not go in too much detail. Ferritin is something easily available, but it has got its own limitations. So what is ideal is cardiac T2 star MRI. Sir has beautifully mentioned that it is not something fancy test. You just have to have a software and you can calculate it. Chelators also, one point only I will mention. Why we need to give daily ion chelation? Why it is very important, oral ion chelation daily? Because only a small fraction of body ion is available for chelation at any given point of the time. So ion chelators will only interact with the labile ion pool rather than a store ion. So daily there will be some ion which will be labile, which will be available for chelation. So if you give a daily dose, it will remove that labile ion. So daily oral ion therapy is more effective. This part has been covered, desferrioxamine, deferiprone or Kelfer. And this is the last one which we are routinely using, deferasirox, Asundra, Desirox or Defriget. Dose is 20 to 40 milligram per kg per day. Very well tolerated. It was little bit expensive, but now the cost has drastically reduced. And rest of the things sir has mentioned, it is most of the government district hospitals now chelating agents are available. If they are not available, you can sort of put your efforts and it will be available. So it is sort of given from the government. We just have to take initiative at our own particular center. Film coated tablets are available, but again the cost is issue and not much superior to the routine chelating agents. Combination therapy is a desperate attempt when the ion chelation is not optimally done with the agents. So this is the proforma. Sir has covered this. This is what we are using at our center. Routinely, we do clinical monitoring with the age, weight, height, then clinical examination like size of liver, spleen, what is the SMR staging of the patient, what is the pre-transfusion hemoglobin range, what is the pre-transfusion hemoglobin the whole year, what patient has received. Then these are the routine investigations. On the left side, they are to be done yearly. LFT, RFT to be done 3 monthly. Serology at least in a year. Then more than 8 to 10 years in the pre-pubertal age group, you have to do the whole endocrinological investigations. And for ion chelation, you do cardiac and liver MRI. DEXA scan has to be done after the 8 to 10 years of age. So again, this is the important point which has not been covered. So I have seen in my practice most of the thalassemia intermediate patients are actually mislabeled as thalassemia major, and they keep receiving transfusion for their whole life. So what is the difference? Thalassemia major, as we have seen, it is a spectrum where transfusion generally starts at the age of 6 months or 1 year, always less than 18 months. Now, these patients will always require transfusion, as sir has mentioned, 3 to 4 weekly in the beginning, and then later on transfusion requirement increases. So they cannot survive without the transfusion. So that is what we'll call as thalassemia major or transfusion dependent thalassemia. But there is something else which was initially labeled as intermediate, now called as NTDT. These are the patients who will generally have a clinical presentation more than 2 years of age. What we mean is up to 2 years of age, generally they don't require transfusion. So they will come to you at the age of 2.5 year, 3 year, 4 year, something like that. You will do a CBC. You will note a hemoglobin in the range of 7 to 8 grams. You will note there is a hepatosplenomegaly, and you will suspect that this looks like thalassemia. Then you will order a HB electrophoresis test. HB electrophoresis test will mention HbF on a higher side. And based on that, you will label this patient as thalassemia and you will start on transfusion. The problem here is it is not a major. It is a patient of NTDT or intermedia where capsule hydroxyurea works beautifully. These patients, you've started in time on hydroxyurea therapy, most of them will respond beautifully to that. Hemoglobin will go in the range of 9 to 10. Your extramedullary hematopoiesis and all other complications are taken care. And usually they don't require transfusion therapy as a routine therapy. Okay, so this is very important point I want to emphasize. I will also emphasize here that electrophoresis is not a sort of reliable or 100% confirmatory to divide them. It is the clinical presentation or the clinical phenotype which differentiates between NTDT and TTD. TTD is something is going to require transfusion. NTDT can be managed with hydroxyurea therapy. Okay, HPLC is not diagnostic. So pathophysiology is more or less same. There is not much difference, but there are more complications with NTDT if untreated. Thrombosis, pulmonary complication, hypertension, leg ulcers, and all these things are there. So hydroxyurea, 20 to 40 milligram per kg per day. You have to monitor CBC, LFT, RFT. Long-term safety and efficacy has been well established, and it is very safe. You are always recommended. Transfusion therapy is very occasionally required. Uh, Whenever there are some complications, fever is there, infection is there, pregnancy is there, some surgery is planned. Only those cases transfusion is required. Generally, with hydroxyurea, they will do well. Even after giving hydroxyurea, if there is no good response, like hemoglobin is low, organomegaly is still persistent, and patient is not maintaining on hydroxyurea, then that is a time where you can shift to regular transfusion therapy. Okay. Now, the general concept is that if the patient is not receiving blood transfusion, he should not have iron overload. But unfortunately, in patients of NTDT, even if they are not receiving blood transfusion, there is a high risk of iron overload. So, there is an increased intestinal absorption in NTDT, which is there in TTD also. But in NTDT, the proportion is more. So, even if the child is not receiving blood transfusion, you are supposed to do serum ferritin or other measures monitoring for the iron overload, and definitely you have to start on iron chelation therapy also. Okay, so intestinal iron absorption is more, which leads to hepatic iron absorption overload, although it is not much in the myocardium. So how do you monitor? You have to do the serum ferritin, liver and T2 star MRI are there. The guidelines are different for NTDT. Even if the ferritin level is more than 800, you are supposed to start on chelation. So the cutoff is less than the TTD. And the chelators are same. There is no difference between them. Okay. Transplantation, again, I will not cover. Atish sir is going to talk on that. Now, the hot topic, thalidomide. So, this has been prescribed to many of the patients. You must have seen your patients of thalassemia major receiving thalidomide, wheatgrass, erythropoietin, and so on. So, all these things are sort of not recommended. There was a paper by pediatric hematology oncology chapter of IAP recently, 2 3 years back only, that these things are not clinically tested in thalassemia major. They are not scientifically proven. So, in cases of thalassemia major, thalidomide and hydroxyurea also is not recommended routinely. Now, the question in NTDT, non-transfusion dependent thalassemia, definitely thalidomide may decrease transfusion requirement, but there is a trial now which PHO chapter has taken to address this issue. Unless the result of the trial are out, I think thalidomide should not be given randomly to all the patients. Let us wait for the results. If it is scientifically proven that thalidomide does work in thalassemia major or thalassemia intermedia, then only we should start on this therapy, because there are a lot of side effects associated with drug. Patients are not monitored properly. Many of the patients have come to us with pancytopenia, infection in a critical condition, and then we have to manage those patients. So I think unless the trials are out, those is sort of fixed. You should not routinely start on thalidomide in thalassemia patients. There is a newer agent which is called as luspatercept. which is a recombinant fusion protein which binds to TGF beta, and it enhances the erythroid maturation. It is already approved between more than 18 years of age. There was a BELIEVE trial which was scientifically tested. The problem is that it just increases the hemoglobin and decreases transfusion requirement. Means it is not going, it's not like if you start on the luspatercept, child will not require transfusion. No, it is not that way. It will just increase the level of hemoglobin. So if you are receiving transfusion every monthly, this might reduce it to 2 monthly or 3 monthly. So even though it was considered a breakthrough, but at least at present, it is not like the transfusion dependency of the patient will go, and definitely the cost is huge. So in India, very few patients who are adult are at present receiving luspatercept. It is yet to receive the FDA approval in pediatric patients. So anyways, we are not using it, but just to be aware that this is something which is in the market, and maybe in future if the cost is reducing and really clinical significant transfusion requirement is reducing, definitely this might be the game changer in future. Gene therapy, as we all know, there are case reports where the gene therapy has worked and the patient has already been cured of thalassemia. So I think this also will, in future, will be the one of the major component of thalassemia as a curative option. Preventive therapy, sir, has already emphasized, very important. There are only two ways to know if your child is going to have thalassemia major. It is always mentioned in thalassemia lectures. The one is to test yourself or to have a thalassemia child and then know that you both are thalassemia minor. So definitely the better way is to have an antenatal testing of the mother, and ideally to have a HPLC screening in the colleges and before the marriage. So that is the ideal one, that even before you get married, you should test for the thalassemia minor. So this was the paper which was published when I was doing my fellowship at Apollo Hospital. That the quality of life in patients with transfusion dependent thalassemia is definitely hampered. So I think now we are moving toward trying to become a developed country. I think bone marrow transplantation, gene therapy, all these things are going to be the future of thalassemia management. Till they are readily available to you, definitely blood transfusion, chelation, antenatal testing, good monitoring, all this will remain the mainstay of therapy. So I think I will end my session, and we will all will like to hear about the bone marrow transplantation from Dr. Atish sir. Thank you, everyone. So this is the summary and take home message from my talk. Thank you, everyone.
Thank you, sir. We'll take the question answer at the end.
Yes, ma'am.
Thank you, sir, for your practical and in-depth approach to supportive care. Now, I welcome Dr. Atish Bakane, the pediatric hemato-oncologist from Nagpur. He will be elaborating on the role of bone marrow transplant in thalassemia and offering us a window with the curative potential. Dr. Bakane, sir, please proceed. Dr. Atish Bakane.
Yeah.
Yeah.
Is my screen visible?
Yes. Yes.
So thank you once again to team Maha AP. Thank you, Pakmode sir and the team for giving me this opportunity to talk on transplants in thalassemia. So as I think most of the supportive care and general overview, prevention, supportive care has been explained by eminent speakers earlier, Rugwani sir and Dr. Tushar Idate. So let us talk about transplantation. And it's a fancy option, but yes, it has to be done in a proper way with proper preparation and proper follow-up care. Then only outcomes are good. So we will try to finish in next 10 to 15 minutes. Thalassemia burden, then see as we talk about transplant, there are different types of transplants. So initially it began with my sibling donor and subsequently to haploidentical transplants. So we will see one by one in brief. So hemoglobinopathies, I think this all of us know that it's a huge burden across the globe, particularly in some areas which it's more common. So before going to the details about transplantation, this recent paper from 2021 suggests that the age of transplantation and how patients were managed earlier has the most important bearing on the transplantation success. Looking at the thalassemia survival in India, in with just supportive care, it was not so good for so many reasons that were very nicely explained by Rugwani sir. Phenotypic classifications and all, I think, has been specifically covered. So amongst these treatment modalities, we will be discussing about allogenic transplants. So whenever we discuss about transplants, we should know about risk benefit ratio. Whenever any particular treatment which is a curative modality, whenever it comes into picture, or when it science produces that, it has to be, you know, compared with the earlier available models. So what modes were there? So supportive care was good. Most of the patients used to do well. Then why transplant have suddenly come up and they are preferred? So talking about the improved supportive care, like now recently it's not about transplant. Only supportive care also has improved. Better transfusion strategies, better iron chelation therapies, combination therapies. There are a lot of support from different super specialties. But yes, despite that, there is a long-term toxicity of iron and quality of life definitely still affected. Talking about transplant, so what has improved? HLA typing. Now we have high resolution typing. A lot of drugs, new drugs have come, and what have been explained by Dr. Tushar. Better monitoring is available in transplant. We do a lot of PCRs, and we are able to find out what are the problems. New anti-infective strategies, better understanding of the impact of iron toxicity. So all these things have improved transplant outcomes. But yes, there are a lot of problems still with transplant, like transplant-related mortality, long-term injury. So these things can happen. So we have to choose what is best for a particular child. It is not only supportive care or not only transplant. The decision has to be taken from the family, and it's a combined decision from a family and a treating transplanter, because not all thalassemic children can be transplanted. Because some in India, I'm talking about India, because many patients come to us in such poor state, class 3 thalassemias, very badly managed, so the transplant outcomes may not be good. So you have to judge what will be best for the child and go ahead with that. So there are a lot of papers on thalassemia transplants. So this being this a pediatric model, I would not be going into details of the transplant papers. But yes, what are the important topics I will touch upon? So what is important in thalassemia transplant is how the child was monitored or monitored and treated before coming to hematologist. Good strategy, good transfusion support, good chelation, and all super specialties should see the child and monitor their monitor their progress over time to keep the child very well for transplant. Particularly iron overload. And iron overload is such one thing which is so important. If it's not managed properly, if liver is affected, the transplant outcomes may not be good. There are different reasons why. We will come to it later. So, management of iron overload before HSCT should be regular and complete as possible before the transplant. So, when you compare the outcomes of transplant strategy versus supportive care strategy, this is the largest paper on that. The 30-year survival rate was almost equal. But you know what was the problem? The problem was quality of life in that non-transplant setting, and with the best quality of support. Despite that, the quality of life was not good, although the survival was good. So whenever we talk about transplant, we should know the history. Everything comes from history, and we learn and improvise, and the outcomes improve. The first transplant was done by our god of transplants, what you call father of metabolic stem cell transplant, Sir E. Donald Thomas. That and the child is alive till now. So as the it progressed from 1982, there are a lot of papers. So Italian group Pesaro, still we follow those classifications developed by Pesaro and Pescarta group. The outcomes, um, the outcomes are so good. So if you see these patients, see this paper, see this graph, the outcomes, thalassemia free survival to the tune of 70 to 80%. It's huge. So a lot of patients. So it's more than 1,000 patients followed up over 30 years. It's a huge data. subsequent to that, yes, so whenever transplants are done, always or any curative modality which comes for particular disease, it comes for the easy patients. So a thalassemic child less than 8 years, well managed, and if you are transplanting, it's good. Subsequently, people try to improvise and see that if the patients are even badly managed, or chelation was not proper, or hepatomegaly is there, so what can be done for the child? Or if the child's age is not less than 8 or 12 years, because in these thalassemics, as the age progresses, a lot of complications happen and they can have problems. But yes, there are different modalities or different transplant strategies that have been developed over the years, and subsequently the outcomes have even improved in the class 3 patients of Pesaro, which I will be explaining in a short while. So most of the papers, you will see the outcomes, phenomenal outcomes. So I was talking earlier about these risk factors of particularly of iron overload in hematopoietic stem cell transplants. So Pesaro gave a classification which is very relevant to the transplant outcomes. So class 1, class 2 and class 3, so hepatomegaly, liver fibrosis and chelation history. These three things are so important in thalassemia transplants. If a child is class 3, for example, a patient is having hepatomegaly, liver fibrosis, there is a poor chelation history, child may not be doing well. So we see these children, unfortunately, in India, we see even class 3 patients at the age of 5, 6 years, huge hepatomegaly, liver fibrosis, because of a lot of non-availability of specific drugs or non-availability of proper blood, which has been in detail explained by Rugwani sir. So see the impact of this. So I can see the graph table 2. In class 1, class 2, the outcome survival is almost 90 to 84%. If you see thalassemia free survival in class 3, it is just 56%. The huge gap of 30%. So that is important. So why I'm emphasizing on this transplant monitoring, treatment and monitoring, is because outcomes are totally dependent on that. It is not only hematologist who is curing or transplanting. The treatment before transplant is as important as transplant. So why does it happen? So that has been dissected in detail. So iron overload can cause a lot of early post transplant complications like infections. Iron can act as a agent, as a feeding agent to some many bacteria. It can increase non-relapse mortality, acute GVHD, particularly liver. It can, and early, these are early post transplant. If you see late post transplant, still the infections can be more. Chronic GVHD, if liver is affected, so that is the most important reason. We see the patients in whom, like we do transplant for class 3 where acylation was poor, we see lot of chronic GVHD, and believe me, chronic GVHD is a very nightmare to treat in the long run. They have to be on long drugs for almost years together. So these are very important things, and that is why Pesaro is Pesaro group was very important in improving the transplant outcome subsequently. Then our CMC group came and they dissected the class 3 risk. So class 3, not all class 3s are bad. If age is more than 7 years and hepatomegaly of more than 5 centimeter, the risk is even bad. The outcomes may not be good. So that is important. Outcomes can be as low as 30%. So it is important and imperative to everyone, all practicing pediatricians and hematologists and all stakeholders of thalassemia management, that pre-transplant treatment should be very good. A brief about conditioning regimens that we use. There are different drugs that we use for transplantation, but I think this is out of scope of this forum. But yes, cyclophosphamide, triosulfan, busulfan, there are a lot of other drugs, sometimes total body radiation. These are the most common drugs that we use, and some GVHD prophylaxis. So matched sibling donor transplantation. So coming before going to matched sibling donor transplantation, let me tell about, because of it's a pediatric forum. So there are different types of donors available for this transplant. Most commonly or most successful in most of the transplant is matched family donor. It may be a sibling, whether boy, it may be brother, sister, or sometimes, very rarely, even your parent can be sometimes full match to the child. Or sometimes in some communities you get in extended family members also, sometimes there can be full match. So it is always good If it's a family match, the outcomes are phenomenal to the tune of 90%. If it is not, then what do? We search for different registries. Like there are blood banks, there are different registries. They have a lot the donors listed all around the globe, and we can select a donor particularly for the child depending on the HLA match, and we can still transplant. That's the second. Third is haploidentical transplant. So haploidentical means haplo means half. So most of the parents they're half matched. So every child has a donor in mother or father. But yes, because it's a HLA barrier, our body doesn't accept which is not completely matched. So there are different strategies for doing these transplants. But yes, haploidentical transplant in thalassemia at present is a clinical option. It's not a standard of care. But yes, in some situations it can be done, and the success it is being successful. Last is cord blood transplantation. Yes, cord blood transplantation can be done, but the outcomes in India are not very good because of a lot of other reasons. We don't get good dose of stem cells in cord. The transplant cost is much because the duration of stay for cord blood transplant is significantly more. The infection risk is more because of the delayed engraftment. So for so many other reasons, cord blood transplant is not that much preferred in India at present. But yes, earlier it has been done. So there are more or less four options, but yes, match sibling donor is most important. So or most successful. So most of the outcomes, if you see all these papers, the graft rejection will be very less, GVHD will be less. All the risks that are there in transplant will be less in match sibling donor. But we know this nowadays there are not many siblings and may not match. We may not get the fully matched donors in all the cases. So there are registries, so we can find out a donor who is matched to our child, and we can still go ahead with the transplant. That is matched unrelated donor transplant. Yes, initially outcomes or mud were a bit not as good as my sibling donor, but over the years with improved GVHD prevention and prophylactic strategies and the rejection prevention strategies, the outcomes are improving, and there are more recent papers to prove that yes, the outcomes are as good as match, if not better than they're as good as match sibling donor transplant. But yes, the donor is different from the family, so there are some risks which are more in matched unrelated donor transplantation. Conditioning regimens, I think I can do not need to talk here. There are different drugs in different combinations that we use. But yes, there are two strategies. Myeloablative way, we use very strong chemotherapy to destroy the bone marrow completely of the recipient before giving. And in there are other strategies like non-myeloablative or reduced toxicity with different agents or some like more of immunosuppressive agents, and the outcomes can be as good as myeloablative. So, as I told you earlier, that for class 1 and class 2 thalassemias, outcomes are good. For class 3 also, slowly the outcomes are getting better because of the different strategies. I need to mention about this triosulfan. This is a drug which has we are using for a long time now, but earlier busulfan was used. So these are some differences within these drugs, which is out of scope of this discussion. But these are the drugs which we can use. So recent protocols are more of reduced toxicity conditioning, which is using triosulfan and all. Depends on, so conditioning regimen depends on many factors, not only patient factors, center specific factors. Some centers prefer some. So it is about transplant outcome. It is not about the drugs. So whatever you are comfortable, your center is comfortable, that is used. So most of these drugs, they are good, and we can do transplant and we can achieve as good results with any other drugs. So high risk. So subsequently, I told you like class 3 thalassemics also, there are different groups who modified the protocol and they produced equally good results as in class 1 and class 2. But yes, that doesn't mean that we should wait for a child to go into class 3. We should try and maintain them in class 1, class 2 and transplant them at appropriate age. So this was a comparison related and unrelated donor, and they're almost equal nowadays. The graphs are touching each other. Then talking about haploidentical, because it's a talk of the town or talk of the country now that haploidentical transplants are coming up in a big way. Why there is a need? Because matched sibling donors are not available. Even if you go for matched unrelated donor in the registries, many patients do not, we do not get donor. And particularly if they are Indian registries and Indian donors, many of them back off. That is our current experience. Lot of donors back off. So many times we are just, we are left with haploidentical transplant. So upfront, we do not advise haploidentical transplant in thalassemias or any benign disease for that matter. But yes, in some situations we have to opt for it, and there are still good outcomes with that. So there are two different strategies. One is a cyclophosphamide post-transplant. Cyclophosphamide is a cheaper strategy, and TCR alpha beta. So there are some T cells which are not needed, which can cause problems, GVHD. We can take out them with some specific that some multi-antibiotic machine, and but the cost is a bit high because it costs around 8 to 10 lakhs for this. But yes, there are centers who are nice, very fantastically doing T cell alpha beta transplants. But yes, what I need to tell you here is that not everybody should undergo haploidentical transplant. I have seen many patients coming to me, and that at the age of 2 years they talk about haploidentical transplant. No, if child is very young and the parents can still get a baby, now we know that with the measures we can prevent a birth of thalassemia, and if they get a match transplant or mud, we can prevent. But if there is no match unrelated or a match sibling subsequently, then we can opt for not upfront haploidentical transplant in any age group. It should not be emphasized, I mean to say. So to conclude, the same slide, if you see, if there is a diagnosis of thalassemia, transplant dependent thalassemia, if age is less than 12 years, we should consider matched sibling transplant or a matched unrelated donor transplantation. No matter what, if they should be properly chelated, properly monitored, and we can go ahead with the transplant. But yes, if there is no matched sibling donor transplant, we can consider unrelated cord blood or haploidentical transplant in less than 12 years. And more than 12 years, yes, it has to be judged. It has to be judged by many factors. If the child is more than 12 years, when we are taking for haploidentical transplant or mud, everything has to be seen properly, because we are not, and transplant is not just done like that. It has to have impact on quality of life of a child. It should improve. Child should do well. Child should live to the fullest capacity. Then only, if a hematologist is convinced that I can give normal quality of life at that point, then only we should advise transplant in such particular transplants. So I think this we discussed MUT and umbilical cord blood transplantation. Outcomes are improving day by day, even in haploidentical transplant. So there are lot of challenges that I discussed in haploidentical transplant. Lot of challenges, but there are rational also because of unavailability of the donors and all. So these are different modalities, and in a lot of Indian papers are also there in both approaches, and outcomes are improving slowly. But the age group is important, in particularly in thalassemia, if we are doing particularly haploidentical transplants. So to summarize, transplant actually is a big topic, but I try to keep to the minimum, because there are a lot of things I think that can be discussed. If somebody has questions, we can take them. In summary, so every child of thalassemia, if diagnosed and if comes in contact with pediatrician or a physician, patient's family should be counseled that this disease can be cured. If the parents know from earlier age that this child can be completely cured, they are aware, however poor they are, they can arrange money. There are a lot of other options also. But unfortunately, till today, what we see in many times, these patients are still not aware. They come from far away places. The transplant is being done successfully. Many patients are not aware, and they come at such a stage that then the transplant doesn't the transplant becomes a challenge. So because why we should tell, because it's a phenomenal outcomes if you do transplant in less than 8 years or 12 years for that matter. If it is a matched related or unrelated, outcomes are more than 85%. They can live a completely normal life. GVHD or allo-related toxicity remains a hurdle, but results are improving slowly. The toxicities, earlier we used to do only myeloid conditioning. It had a lot of complications, but slowly that strategies are changing and long-term toxicities are being controlled very well. And yes, with the availability of so many other things, good prevention, good prophylaxis, good treatment modalities, good protocols, good follow-up care, the myeloma transplants and haploidentical transplants are also improving slowly. And yes, I think after this we should know that gene therapy and gene editing will definitely come into picture in recent future. And I think transplant versus gene therapy will be a debate, or gene therapy, gene editing is going to take away. But for now, till we are here, I think allohCT in thalassemia is a standard of care at present. So every child of thalassemia should live a normal life, and I think should be at least given a fair chance that child can should be transplanted in less than 8 years. At so then I think all stakeholders should get that message that yes, every child or every family, whatever poor they are, they should be at least told that this modality is available and it can be done. And what is good, that these centers are everywhere in India now. Almost all of the big cities have good thalassemia or transplant centers. So I think it's a matter of just refer the child, let hematologist decide whether this child can go for a transplant or not. Thank you so much for patient listening.
Thank you, Dr. Atish. Any questions from audience?
Yes. First of all, wonderful presentation. I just wanted, is there any relation of the serum ferritin with the bone marrow transplantation?
Absolutely, sir. So serum ferritin is important. So what ultimately serum ferritin is iron toxicity. So what we have done is the Pesaro group has done is quantified it, not only ferritin, because ferritin is a misleading, sometimes can be misleading, but we try to bring down ferritin to the lowest level. We measure so many things, modalities are there. So if ferritin is high, we definitely want it to be less than 1,000. Sometimes it is difficult to bring ferritin less than 1,000 in many patients, depend, because patients they are not managed that well. So we have to go for cardiac MRI and liver MRI. Particularly liver MRI becomes a very important thing, or sometimes liver biopsy, liver is affected or not, because whatever conditioning agents we use, they usually affect liver, and the outcomes can be bad. So yes, ferritin is important, but subsequently, like, you should go for Pesaro classification, find out how is the liver, how is the heart, because sometimes even with 2,000 we have to take the patient for transplant if all these things are good.
And the soft organs have special affinity for the iron deposition. So, what is the prevalence of the diabetes mellitus in these children? Na? Is it common, rare in
It is
pancreas?
not that common, sir. If we manage the children very well, it is not that common. But yes, that is why so earlier what used to happen, that everybody was, it was like a one doctor treatment set. But now we know we have a lot of super specialists available. So it is our duty to send to endocrinologist and monitor them. So if with that, I think the chances have gone down significantly.
Thank you, Sanjay sir and Amol sir.
Yes, sir.
Such a wonderful webinar, and all three speakers, they have spoken excellent, outstanding.
Yes,
And
yes, yes.
congratulations. Thank you.
Thank you, sir.
Thank you, Atish.
Any more
Thank you.
questions?
All are busy with the watching on the television because recent
Or
news
is
is Lahore has been attacked by India.
yeah. And Jammu Kashmir is completely blackout now because they
Blackout.
can
All the areas nearby Pakistan border.
borders.
Yeah.
Yeah.
These days we have to, you are very true in saying, जो ये अफवाहें उड़ाते हैं ना कि ये हो गया, this is, we have to be very careful regarding that ना.
Yes,
So
yes.
still life is also disturbed usually ना, unpredictable.
Completely
Thank
unpredictable.
you.
So I think we should wind up with that note.
Yes. Pallavi
On behalf
madam.
of Maharashtra IP, I extend my heartful thanks to all our esteemed speakers for their enlightening and concise presentation on thalassemia. And your expertise and clarity have truly enhanced our understanding of this critical topic from its basic to beyond. A special thanks to our guest of honor, Dr. Vinki Raghuvani sir. We are honored to have him on this platform. Our other speakers, Dr. Tushar Idhates and Dr. Atish Bakane, for delivering the powerful and practical insights. I thank our President, Dr. Sanjay Pakmode sir, and Secretary Dr. Amol Pawar sir for providing this wonderful platform and considering this topic for today's session. And I also extend my thanks to Pallavi ma'am for the technical team and all the office bearer of Maha AP, and our of course our audience. Thank you for your presence and active participation. Let us continue to stay informed, advocated for the early screening, and support every child and family affected by the thalassemia. Together we move towards the better care and brighter outcome. So with this note, I say good night and stay healthy.
And thank you, Kashmiri, for wonderful
So
moderation.
one quick one. Thank you so much on this Thalassemia Day. Thank you so much for all the contribution by all the